So you might see HER2 is often in the literature referred to as ERBB2, so we typically use these synonymously. It's detected in approximately 2 to 3% of patients with non-small cell lung cancer. Here in this pie chart is some data from a multi-institutional cohort of over 700 non-small cell lung cancer patients that underwent genetic sequencing. And you can see here that the ERBB2 or HER2 mutation rate was 2.7% in this population. When you look at a larger population, this is the American Association for Cancer Research Project GENIE, which is an international cancer registry that contains genomic information from a number of different cancer types. In non-small cell lung cancer, this involves over 10,000 patients with genetic sequencing. And then here at the top, you can see that ERBB2 mutations are present in about 3.1% of this population. In preparation for this talk, I had the opportunity to pull our own genetic sequencing data in our lung cancer cases. And in our Penn lung cancer genomics data, where we've sequenced over 4,000 lung cancer cases, the HER2 mutation rate was approximately 2.8%. So this 2 to 3% in non-small cell lung cancer has been pretty consistent across a variety of different cohorts. This specific mutation appears to be mutually exclusive with other oncogenic driver mutations. So if one is identified to have a HER2 mutation, you're unlikely to have an additional oncogenic driver mutation in EGFR or ALK or ROS1, for instance. The majority of these mutations occur in exon 20 as either an insertion of amino acids or a duplication of exon 20. And then similar to other oncogenic driver mutations, HER2 mutations tend to be more common in female in patients who are never or light smokers and that have an adenocarcinoma histology. HER2 mutant non-small cell lung cancer patients have a high incidence of brain metastasis during the course of therapy. So this was a study looking at brain metastases in patients with HER2 mutations compared to other subtypes of non-small cell lung cancer. And you can just highlight in this pie chart the kind of red section here, which are patients who develop brain metastases on treatment. And you can see that the patients with HER2 mutant non-small cell lung cancer tend to develop brain metastases on treatment at a higher rate than some of the other molecular subtypes. So this is just something to keep in mind when thinking about novel targets for HER2 mutations and whether they have CNS penetration, and for designing clinical endpoints of clinical trials and monitoring these patients on therapy. The current first-line standard of care for patients with HER2 mutant non-small cell lung cancer still remains to receive chemotherapy plus immunotherapy combination. We do have some data to suggest that patients with HER2 mutated non-small cell lung cancer have similar outcomes and response rates to chemotherapy, immunotherapy regimens compared to an unselected population of non-small cell lung cancer patients. However, a big question in the field is really, can we do better and improve outcomes in these patients by specifically targeting the HER2 signaling pathway? And so just a little bit about the HER2 signaling pathway in general. So you can see HER2 in the little blue receptor here. It is part of a HER receptor family, and that family includes HER1 or EGFR. And typically what happens is that a certain stimulus binds to one of these receptors, and then these receptors come together. And that activates a downstream signaling pathway that then tells the cell to grow in an unregulated fashion or develop resistance to cell death and enable it to metastasize. And when the HER2 receptor acquires a mutation in it, this no longer requires a specific stimulus. This activation pathway is always on, telling the cell to constantly grow, develop, and be resistant to cell death. And so really the major goal in developing specific drugs to target this pathway is to really stop this activation pathway and inhibit this downstream signaling and induce cell death in these HER2 mutated tumor cells. And so over the last 2 decades, there has been a tremendous amount of work and progress made in targeting the HER2 signaling pathway. And I've just highlighted the main drugs that have been developed to date. These involve both non-selective and selective tyrosine kinase inhibitors. And these tyrosine kinase inhibitors bind the intracellular domain of the HER2 receptor, kind of blocking this downstream signaling, causing cell death. There are also HER2 monoclonal antibodies such as trastuzumab that bind the extracellular domain here. And then more recently has been the development of anti-HER2 antibody drug conjugates. So these are monoclonal antibodies directed towards the HER2 receptor that attached to these are chemotherapeutic agents. And so what happens is these monoclonal antibodies bind the receptor. That receptor is then internalized, thus releasing the chemotherapeutic agent into the cell, inducing cell death. So HER2 targeted therapy has been very effective in other tumor types, and now there are a number of HER2 directed therapies approved in both breast cancer and gastric cancer. So really a major question in the field has been, can we apply these same therapies in HER2 mutated non-small cell lung cancer?